Hello, you're all very welcome to this discussion on reproductive rights in 2020, with a particular focus on abortion and the impact of the COVID-19 pandemic. This is, of course, one of those issues that we could run a series on this alone, covering the impact of the global health crisis on reproductive rights in many countries. But for this event, we're going to be hearing about the situation in the US from our friends in the Centre for Reproductive Rights. We're also going to hear from Mary Stopes International on their global programmes, including in India, Nepal, South Africa and Zambia. I'll be updating on the latest with our campaign in Northern Ireland, and we'll be hearing from our long-time partners on this issue in Northern Ireland, Informing Choices NI, who will talk about the interim emergency response to providing early medical abortion healthcare during this pandemic. Before we get to our first speaker, let me begin by saying that we are deeply concerned by the disproportionate adverse impact of the COVID pandemic on women, girls and pregnant people. Moreover, again, those from marginalised communities who face additional challenges due to the structural inequalities that are being exacerbated in the context of the global health crisis. The diversion of healthcare capacity to respond to the pandemic has meant that people have reported struggles with accessing essential sexual and reproductive health services, particularly time-sensitive services such as abortion and emergency contraception. The need for an abortion doesn't stop for a pandemic, and indeed may be increased, particularly if we consider increases in domestic and sexual violence. Since the beginning of the COVID-19 crisis, there have been very worrying developments in some countries where governments have pushed abortion restrictions or total bans in new legislation being developed to respond to the crisis. In some countries with already restrictive abortion laws, women, girls and pregnant people are no longer able to travel to, for example, neighbouring countries to receive abortions. So how the event will work is you'll hear from each of us, who will update on our own country contexts, before then having the opportunity to put questions to us. For those of you who are following on Twitter and YouTube, please note that questions can only be submitted on the Amnesty UK Facebook page. So we're going to begin with Elizabeth Smith, who is Chief Counsel for State Advocacy and Policy in the Centre for Reproductive Rights, who's going to inform us about the situation in the US and the work they're undertaking to address this.
Thank you so much and good evening. I'm happy to join all of you today for this conversation. I'm going to speak about access to abortion and reproductive health care in the US during the COVID-19 pandemic, and specifically 4 main issues that impacted access. 1, state orders issued to healthcare systems and providers. 2, state orders issued to individuals. 3, new rules issued by hospitals. And 4, the loss of job-based health insurance. But broadly, what we have seen during COVID is exactly what we've seen for years. There are state legislators, federal legislators, and anti-abortion activists who have been pursuing a coordinated campaign against abortion. These people have exploited this crisis to advance their decades-old campaign to shut down abortion clinics in the US. These attacks came despite consensus among leading medical organizations in the US and globally that abortion continues to be essential during the COVID-19 crisis and therefore must remain accessible. I'll start with the state orders. In response to the COVID-19 pandemic, state governments around the country issued a variety of orders intended to stop the spread of the virus. So, starting with state orders to healthcare systems and providers. Numerous states issued orders directing hospitals and providers to postpone non-essential or non-emergency surgeries and procedures. Some states affirmatively stated that abortion or reproductive health care is essential. Some states left the determination of what is essential up to healthcare providers themselves. Other states, like Texas and Oklahoma, said explicitly that abortion is non-essential and that abortion care would have to stop. All in all, 10 US states issued orders that they said prohibited abortion during the pandemic. Their stated rationale was the conservation of personal protective equipment, or PPE, but some states like Texas even prohibited medication abortion, which does not require large amounts of PPE. The Center for Reproductive Rights and our partner organizations, including the American Civil Liberties Union and Planned Parenthood Federation of America, immediately went a court to stop these states from enforcing these orders. However, in many states, there were delays in care. In Texas, the district court kept blocking the state's order, and then the state would appeal to the Fifth Circuit Court of Appeals, which kept reversing the district court. This back and forth meant that abortion care was unavailable in Texas for almost 3 weeks this spring, which is the first time that has been true since before Roe v. Wade was decided in 1973. Pregnant people in Texas and other states had to travel to seek care when these orders were in effect. As people in Northern Ireland and Ireland know well, being forced to travel for abortion care is a human rights violation. And the states that exploited the pandemic to stop abortion care also prohibit the use of telemedicine for medication abortion, which in practice requires pregnant people to make 1 or sometimes 2 trips to abortion providers in order to access the pills they need. In the US, 18 states prohibit the use of telemedicine for medication abortion. Finally, many of these orders have expired because the states that sought to prohibit abortion are also states that have decided the pandemic is over and it's business as usual, which means that their excuses for prohibiting abortion are no longer available to them. However, we expect that these states will reissue similar orders when we get the second wave of COVID-19. So turning to state orders to individuals, the vast majority of states have restricted individual travel. However, these orders broadly defined categories of essential services, and most orders allowed people to travel for healthcare. Whether people felt comfortable leaving their homes to access care is another question, of course. Some states also required people arriving from out of state by air or by road to self-quarantine for 14 days. Most of these orders included exceptions for people who were seeking essential services, like healthcare. However, these exceptions were not made known to people who had not read the text of the orders themselves. Texas, for example, set up checkpoints on highways just over the border from neighboring states and required people with out-of-state license plates to fill out forms listing where they live and the address in Texas where they were headed. Advocates trying to help people travel from one of the 10 states that prohibited abortion because of COVID had to figure out where pregnant people could go and how they could get there safely. And then looking at hospitals and healthcare systems, in addition to the state orders I've talked about requiring the conservation of PPE, hospitals issued new rules about how to provide care. Many hospitals, including some in New York City, issued rules that prohibited a support person for pregnant people in labor and delivery. Many organizations and individuals spoke out against these rules. Even though it's important to limit the spread of COVID-19, maternal health care advocates argued that support people ensure better health outcomes for pregnant people, especially for Black women, who experience much higher rates of maternal mortality and morbidity because of systemic racism. As a result of this advocacy, most hospitals reversed these rules and allowed pregnant people to have a support person during labor and delivery as long as the support person tested negative for COVID. And then looking at job-based coverage, many millions of people in the US have lost their jobs as a result of COVID, and many have also lost job-based health insurance. While there are some private and public health insurance programs that some people could take advantage of, the loss of health care endangers people's access to reproductive health care broadly, including contraception, abortion, STI testing and treatment, etc. So what's next? In the US, we are waiting to hear from the Supreme Court on a case called June Medical Services v. Russo, which the Center for Reproductive Rights has been litigating since 2014. This case is about a law from Louisiana that requires abortion providers to have admitting privileges at a local hospital. The law at issue is identical to a Texas law that the Supreme Court found unconstitutional in 2016 in a case called Whole Women's Health v. Hellerstedt. If the Supreme Court decides that the Louisiana law is constitutional, states that are opposed to abortion rights will likely double down on enacting new abortion bans and restrictions. Also, June Medical Services came from the Fifth Circuit Court of Appeals, the same appellate court that allowed Texas to stop providing abortion care during the pandemic. Thank you so much.
Okay, thank you so much for that, Elizabeth. We're now going to hand over to Sarah Shaw, who's the Head of Advocacy with Mary Stopes International, and will tell us about how access to abortion care has been affected where their global programmes are present.
Thank you, and thank you for the opportunity to speak, and it's great to be here with everybody this evening. So Mary Stopes International is a global provider of contraception, abortion and post-abortion care services, as well as advocating for women's access to sexual and reproductive health and rights. We work in 37 countries across Latin America, Africa and Asia. Fortunately, in the UK and in the US, unsafe abortion for now is predominantly a thing of the past, but in the countries that MSI works in, sadly this is not the case. According to the Guttmacher Institute, almost half of all abortions that will occur this year, which is an estimated 25 million, will be unsafe. And 7 million of those women and girls will suffer devastating injuries, and an estimated 22,000 women and girls will lose their lives due to a lack of access to safe abortion and post-abortion care, which is a life-saving emergency treatment following unsafe abortion. Under COVID-19, we have seen the impact on abortion access and reproductive rights across our country programmes to varying degrees, with lockdown restrictions preventing women and providers travelling to services. Women are also scared about accessing health centres for fear of contracting COVID, and governments failing to define safe abortion as an essential service. This means that in some countries, services have been closed and women have not been able to access services. We know from former crisis that the need for reproductive health care does not go away. During the Ebola epidemic, at least as many, if not more people in Sierra Leone died as a result of the barriers to accessing maternal and neonatal health care as died from Ebola itself. We also know that during lockdowns, rates of sexual violence can increase and reduce access to contraception, and this will lead to additional unplanned pregnancies and unsafe abortions. And we know that women are still seeking care despite these huge barriers. In Ghana, we've seen a 400% increase in calls from people seeking information to see if services are still open and to see if they're still available. So a really big priority for our programmes over the last 3 months has been to work with governments to define safe abortion and contraception as essential services, so they're part of the state's essential package of services, and so they can continue to stay open and serve women throughout the pandemic. In Nepal, for example, the government was really fast to declare safe abortion and contraception as essential, and this was really important because Nepal has one of the more liberal legislative frameworks for abortion access. So keeping those services open for women through the pandemic was absolutely critical. So in addition to permitting women to travel to seek services and permitting our providers to go to work, they also issued new guidelines, which mean that abortion pills are now available to be provided in clients' homes, and that telemedicine is now going to be available. And although these are temporary measures for COVID, these are measures that can really increase access and that we've been advocating for quite a while. So we're really hoping that this time will act as a proof of concept, and then when this crisis passes, we can then advocate for this to become a permanent measure. Not all countries have had such an effective response. In India, where abortion is similarly relatively unrestricted, and the government did designate it as essential, but this didn't flow down to all the states, and data that came out this week from IPAS indicates that 59% of women needing an abortion in India during lockdown were not able to access services. During this time, our contraceptive services were closed as well because we weren't allowed to open, which meant that women didn't have the means to prevent unintended pregnancy. And it's really only now this week that our centres are reopening. We've now got 3 clinics open for abortion and post-abortion care. And going forward, the government has also given permission for telemedicine, which is a positive move. Telemedicine has really provided an opportunity for innovation and increased access to abortion services under COVID. In the UK, the Department of Health has permitted telemedicine for medical abortion under COVID, and we've had a long-standing telemedicine programme in Australia, and more recently South Africa is our first African programme where the government has designated telemedicine as a viable channel for providing abortion services. So under telemedicine, we would send the pills via the post or a courier, and this is following a remote consultation between the provider and a client. So evidence has found that medical abortion services via telemedicine, they're safe, they're effective, often women prefer them. And under COVID, they've really helped prevent unnecessary journeys, reducing contact between client and provider. And this has been reducing anxiety, both for and risk, both for providers and for clients. We've seen innovation in other areas as well, in Madagascar, where there were very severe travel restrictions. So there was no public transport. Women were not able to access SRH services or maternity services. But because the vehicles of our programme had permits to travel, because we were part of the health response, so we used our vehicles to run a bus service to collect women, socially distanced, of course, but to drive around the community, collect women, bring them to the centre so they could access their services. And in Zimbabwe, contraception was also designated an essential service. So we partnered with the World Food Programme and immunisation teams to deliver services in remote communities. But despite family contraception being designated as an essential service, the lockdown in Zimbabwe was severe, and a lot of women reported harassment by the security services on the way, who didn't believe them that contraception was an essential health service, and therefore they had a right to be moving. And sometimes because of stigma as well, the women were just too ashamed to assert their rights. And we really shouldn't forget that, in countries where abortion is there's relatively liberal legal frameworks, so there is a degree of access, but in many of the countries in which we work, abortion is highly restricted. So even before COVID, women's access was restricted by legal limitations, by stigma, or challenges in the health system. Zimbabwe is a good example of this. In Zimbabwe, there's always high rates of gender-based violence before COVID. The initial data is indicating that it has massively increased under COVID. Abortion is quite restricted, so most women are resorting to unsafe methods. And of post-abortion care clients, 19% of those women will experience severe complications. Nearly half of the women will have to visit at least 2 facilities to get appropriate treatment. And this will often happen across a number of days while they're seeking treatment. So at the moment, this is what's happening before lockdown. When the data's now got to catch up with what's happening under lockdown. But I fear what's happening behind closed doors is now even worse. And generally across the board, there's a concern that as we emerge from lockdown and women have either been forced to delay seeking services or have just delayed seeking services, we're going to see an increase in second trimester abortions. And in some countries, second trimester abortions could be legally restricted, or maybe there will be health system restrictions in that there won't be trained providers able to provide those services safely. We know from our programmes that governments play a key role in deciding whether women can access a safe and often life-saving service or not. So in terms of things that we would like to see governments doing in the future to ensure access to essential abortion and contraception services, all governments should be declaring contraception, abortion and post-abortion care as essential services. Even in countries where abortion is highly restricted, post-abortion care is an essential service, and that's often a constitutional right in many countries. So absolutely, it should be part of the package, and women should be able to access those services. We also want to see the innovation that COVID has catalysed, for example, telemedicine. We'd like to see these temporary innovations made permanent post the pandemic. In restrictive settings, we need governments to lift the legal restrictions around access to abortion. We recognise that this is long term. So in the short term, efforts need to be made to ensure that access to emergency services such as post-abortion care is maintained. We need to maintain investment in sexual and reproductive health and rights. We know that COVID has put health budgets under terrible pressure, and we know that ministries of health are looking to find resources to help cope with this pandemic. But taking from the sexual and reproductive health budget lines is not the solution. Investing in sexual and reproductive health builds resilience, which means we're better placed to cope with similar crises in the future. Thank you.
Thank you, Sarah, for that. So I'm now going to just do a bit of an update on where our campaign and work has got to in Northern Ireland. I know for a lot of our supporters, this has been a campaign that you have stayed with us throughout the years we've been working on this. But I just want to begin by saying that COVID, as we know, has flushed out a lot of the inequalities that we knew existed in our society, but were often ignored and in some cases hidden from view. For others, like the issue of reproductive rights and including access to abortion healthcare, these are inequalities which are well known and which regrettably the pandemic has been used by some, including in our own government, as a convenient smokescreen to roll back, delay and deny these rights and access to this healthcare. So I think it's really important that it's time now for us to reflect quickly and decide what kind of society we want to be in each of the countries and regions that we live in, but of course within Northern Ireland and within the UK, are we going to be one that respects, promotes and protects rights, or one that continues to perpetuate the inequalities and discrimination which are a reality for many, including women and girls? I mean, this is obviously why we on this panel and others are working on a daily basis to tackle these and send a very clear message to government and others that we will not accept these abuses and we will challenge and fight at every step. But on Northern Ireland, if we first consider our current position, which is we had historic law reform, which was passed in 2019, overturning our near 160-year-old abortion ban. The healthcare was decriminalised. We're the only part of the UK where that's the case. And it was made lawful in line with CEDAW recommendations, which followed an inquiry that they conducted on Northern Ireland. It was an overwhelming landslide majority in the UK Parliament that sent a very clear message to Northern Ireland that they stand with us and that they will vindicate our rights when our own devolved government fails. Following that law reform, we had new abortion regulations, which provided a framework for services in Northern Ireland, and they've been in effect since the 31st of March of this year. They're, will shortly be completing their parliamentary procedure, but effectively what that framework means is that our NHS Health Trust can provide these services. But COVID, like elsewhere, has obviously presented challenges and some new and unforeseen barriers for how people access these services. And again, we're seeing our local government in Northern Ireland failing women and girls and pregnant people by refusing to put in place straightforward measures to ensure the availability and accessibility of abortion to all who need it. So both our speakers, Elizabeth and Sarah, have already touched on the issue of telemedicine. But of course, that is an essential way of delivering this healthcare, particularly during times of a pandemic. England, Scotland and Wales already have measures in place to enable the safe self-management of abortion at home through the use of both abortion pills, otherwise known as telemedicine. And this is absolutely the right and safe thing to do, particularly in a health crisis of the scale that we've been living in. Our new abortion regulations have really been an opportunity to provide for this. And at the time when they were being still developed, we strongly pressed the UK government to ensure that telemedicine was provided for in the regulations. Ultimately, like we see so often with this issue, for political reasons, this failed. And it was then left to the Northern Ireland Department of Health to do this. Our Northern Ireland Department of Health, our health minister, then decided that this was a matter for the Northern Ireland Executive, which is like the equivalent of Cabinet. And these proposals were then blocked, which meant that we were the only part of the UK without access to telemedicine during this pandemic. And of course, that decision not to allow women and girls, those facing crisis pregnancy, to safely self-manage their abortions at home, it's dangerous, and it has been putting women and people needlessly at risk. Travel for this healthcare, particularly at the moment, is neither a safe nor viable option for many. And we were frankly astounded by the hypocrisy of government advice to stay at home, but then not actually taking the steps to enable that by making telemedicine available. It has just been hugely disappointing and insulting that our government is once again leaving Northern Ireland behind rather than prioritising the health and well-being of women and girls. For many in vulnerable situations who we would hear from, particularly those who are either shielding, for example, due to underlying health conditions, or are in abusive relationships, or those who have an insecure immigration status, travelling has never been an option. And allowing the option of telemedicine would really be a crucial way of ensuring that it is accessible, particularly to those who are in those positions that I've described. I mean, if we look, for example, at domestic violence, we know that domestic abuse levels are at an all-time high, and that being in lockdown with your abuser has only worsened this. Several have already lost their lives during lockdown to this violence. So providing this healthcare to those who, for example, are victims of spousal rape is the least our government can and should be doing. We know of cases of women who during lockdown and just prior to the regulations taking effect were making 3-day round trips on the ferry from Belfast to Liverpool. Others who sadly have made attempts to take their own lives. So the situation that we have seen here during this global health crisis is quite grave and urgent. And since the beginning of it, we have been pressing both our own government here, the Northern Ireland Department of Health, and the UK government, specifically the Northern Ireland Office, to put in place these very necessary measures. The Northern Ireland Office can, at any point, refresh our new abortion regulations to provide for telemedicine. And you can support these calls by signing our petition, which will be available on your screen. Over 12,000 have already joined us on this. But the UK government has ongoing responsibilities here. The fact that they have supported our law reform and they have supported these new regulations is not job done. They have to ensure that our regulations are given effect in practice. And if necessary, that includes exercising their powers to tell our Department of Health here to commission these services. Without the commissioning, we will not have a well-resourced service to ensure that it's accessible to everyone who needs it, nor will there be clear pathways to this care. The Northern Ireland Office also needs to fund these services, and where the Northern Ireland Executive continues to fail, they have to stand by people here and once again do what our devolved government is failing to do. So in terms of then emergency measures that have been put in place, which our other speaker, Rory Rowan from Informed Choices, will speak about shortly, let me just say that we have welcomed some of the innovative responses in the absence of government leadership, and that has included the establishment of a new central access point. That is providing a much needed interim local pathway to early medical abortion services. But it is very much an emergency response to the COVID pandemic, and there are question marks over its sustainability. And the fact that we have some form of abortion services in place does not remove the pressing need for both the telemedicine measures that we have discussed, and also then for our Department of Health to urgently commission these services. So we repeat our call this evening to government to deliver this urgently. Work is continuing against a very hostile political backdrop, with some intent in their efforts to roll back our rights. But we in Amnesty are determined that they won't succeed, that there will be no going back to the rights that we have, that have been hard fought for and now secured. Which leads me then to the trailblazing response that we've seen put in place between our health trusts and Informed Choices NI, which I'll now hand over to Rory to outline.
Well, thank you, Grania, for that introduction and for enabling me to speak this evening about that interim response to COVID and the early medical abortion services that are now available in Northern Ireland and that Informing Choices are providing the central access point to. Just before I begin, I know Grania had mentioned about the new regulations which have recently been introduced. It's important to remember kind of where we have come from in Northern Ireland in terms of the law. We had the most restrictive law, or one of the most restrictive laws in Europe, a law which carried the harshest criminal penalties anywhere in the world in terms of life imprisonment. And we've seen that people were being actively prosecuted in Northern Ireland over the last number of years for accessing abortion pills online. We have seen those regulations now changing the law in Northern Ireland and changing some of the landscape here. In the lead up to their introduction, we were receiving a number of calls to our helpline because we'd seen previously the fact that women from Northern Ireland were being forced to travel through a UK funded scheme from Northern Ireland to England, or being forced to access abortion medication online. We had seen in that period towards the end of March and at the beginning of April where people were being denied access to services because we had seen we're coming into contact with people whose flights had been cancelled, people who could not access abortion medication online and were being left without any access to services and no course to access them in Northern Ireland. So we, as an emergency response, worked very quickly with local medical professionals who wanted to provide these services in Northern Ireland to come up with an interim solution that women could access abortion services without being forced to make, as Grania had mentioned, a overnight ferry from Belfast to Liverpool being one of the only measures that people could travel on. So a 3-day ferry journey is no way acceptable in order to access this vital health care. So we were working with medical professionals in Northern Ireland to come up with an interim response, to come up with early medical abortion services so people could access those services within Northern Ireland. And we have done so by Informing Choices providing a central access point, providing a single contact telephone number where any woman or girl in Northern Ireland can contact and be assured that they can either be referred to services or access pregnancy counselling. So that service was launched on the 15th of April. And how it works is essentially we had some of the infrastructure already in place. Informing Choices already had a sexual health helpline in place, and we were already providing pregnancy choices and post-pregnancy counselling. So we were already one of the go-to organisations for people who wanted to access abortion in Northern Ireland. We were seen as a first point of contact. So we stepped in to provide that central access point to local healthcare. So women can now contact a single telephone number. And I can talk you through how that process works. They will speak with one of our members of staff who will first discuss their pregnancy options, which are continuing with a pregnancy, adoption or abortion. We will start every conversation with this question because we would never want to make assumptions around a person's personal circumstances or their thinking in relation to the pregnancy. So we'll ask them about their pregnancy options, whether what they would like to do in terms of the next steps in relation to the pregnancy. If people are undecided, we have access to our Pregnancy Choices counselling service, and we can directly refer people in for a counselling session. Because of COVID-19, we have changed the way that counselling service is provided. So while previously that would have been a face-to-face counselling service, it's now being provided over the telephone, which is giving greater access to people across Northern Ireland to access that service. If someone has decided that they no longer want to continue with the pregnancy, we will discuss the change of law in Northern Ireland, the services that have now been established, and the next steps in terms of accessing those services, including referral into those services. As Grania mentioned, we have not had access to telemedicine in Northern Ireland, so the regulations do require people to attend a local health and care clinic to take the first abortion pill. they can then take the second set of abortion pills at home. It is a change, as Grania said, as Amnesty and ICNI and others had campaigned for telemedicine. Unfortunately, that is not in place at the minute, so people do have to access the abortion medication in a clinic. But for many, it is still a far better outcome than what was in place previously, where people were being forced to travel or being forced to purchase pills online. This care is now being provided within Northern Ireland, within the health and social care trusts, and aftercare is also provided as well. When we first launched the service in April, 3 out of our 5 local health trusts were providing the service. Women across Northern Ireland could access the services, but at that stage we only had 3 of the health trusts providing them. That has moved to 4 last month, and from next week we will have early medical abortion services in all of our trust areas, so women can access that. So we are starting to see greater access to the services in Northern Ireland. We have arrangements with the trusts, whereas if someone who English is not their first language, we can directly refer, and translation services will be put in place. We have a process where anyone under 16, ICNI will provide the safeguarding. We'll do Gillick competency in terms of their ability to consent to medical treatment before referral into the trust, and we also continue to provide post-pregnancy counselling, and I think that's very important for people to be aware that they can access that support afterwards, but also important because many of the people who we are speaking to currently, they've had a number of previous pregnancies, and they've had different pregnancy experiences, which would include miscarriage, traumatic birth, prenatal anxiety following previous pregnancies. So it's important that they are also aware that they can access post-pregnancy counselling, and that additional support is available to them through informing choices as well, that there is no cost to access the counselling service, that there is no limits on the amount of counselling sessions that they can attend, and that support continues to be available to them. As Grania said, this is very much an interim service, and at the minute there is currently access in all trusts in the first 10 weeks of pregnancy. We know our new regulations go beyond that, go to 12 weeks, and we hope that very shortly we will have a greater access to that. But as Grania said, we do need commissioned services. This was very much an interim response to COVID, to the fact that people were being denied access to services. So we need fully commissioned services in all trust areas to ensure this long-term sustainability of these services. This is vital healthcare, and it cannot be left up to willing healthcare professionals to step in and provide the services, to organisations like ICNI to temporarily step in. It needs to be a fully commissioned service. It needs to be sustainable in the long term, and it also it needs to go beyond just access to abortion. We have not had a sexual health strategy in Northern Ireland since 2015, and because of that, there has been those services have suffered from a lack of investment, including a number of our contraceptive services in Northern Ireland. We have seen reviews into sexual health services in Northern Ireland come up with recommendations, including better access to long-acting reversible contraception, about consultant-led services, and yet those recommendations have been sitting since 2013 and have been unmet. We also need to see relationships and sexuality education in Northern Ireland that is fit for purpose. Currently, while it is a statutory element of the Northern Ireland curriculum, there is no uniform pattern to the provision of RSE in Northern Ireland, which means that individual schools, depending on their ethos, can opt out of what they would deem to be sensitive subjects, and some schools may deem issues such as puberty to be a sensitive subject. We don't think that's acceptable, and we've seen in terms of the legislation that has come forward to grant greater access to abortion, that also contain provisions for greater access to contraception, and also for abortion and access to contraception to be mandatory elements of the curriculum in Northern Ireland. So that we need to see that. We have seen from research from young people that RSE currently in Northern Ireland is unhelpful. We need to see a uniform pattern to its provision that is fit for purpose, which is rights-based and which meets the needs of young people. So we need to see a number of things going forward. Long-term, sustainable abortion services which fully comply to the regulations that we have in place, better access to contraceptive services, and compulsory sex-positive relationship and sexuality education. But certainly, we are now in a better place than we were 8 weeks ago, and hopefully in the months ahead, we will see things move forward again. Thank you.
Thank you for that, Rory. So one of the first questions that has come in is maybe a nice, easy one for us to start with. But for those who are watching at home and want to support the work that each of our organisations are doing, if each of you could just say a little bit about what's the easiest way for viewers to do that. If I start just from an Amnesty point of view, I would encourage you to, an easy step tonight is to sign up to our action, calling on the Northern Ireland office to ensure the accessibility of, for example, telemedicine, and to exercise their powers to put that in place, because we simply don't think that the Northern Ireland Executive are going to agree to that. And if we are looking at a potential second peak of this COVID pandemic, then it's vitally important that we have that in place. But if we maybe then go to Elizabeth to begin just on that.
Sure. So what we know in the US is that voting is really critical, and we have very important elections coming up in November 2020. And so I would urge everyone in the US to register if you're not registered, to vote, and also to regularly call your state representatives and state senators and tell them that you support abortion rights and abortion access. The sort of secret of state legislative work is that one person can actually have a really big, can actually move a legislator to support their issue. It doesn't take thousands of people. It can really just take a small handful. So vote and regularly tell your legislators that you support abortion rights.
Okay, so Sarah.
So yeah, I think for an international context, there's a couple of things that your listeners could do. First of all, a lot of abortion restriction is driven by stigma. So the first thing they can do is contribute to efforts to really reduce stigma and talk about abortion, share your stories. There's lots of campaigns out there to really help generate a noise around this. And the more we talk about abortion, the more we'll normalise it. And then the more access there will be. I think the second piece is, in the countries that most OAPS works in, we're heavily dependent on donor funding, and the generosity of the UK government and the other European governments means we can carry out this work. But looking forward and looking at the devastating economic impact that COVID is going to have, it's going to impact aid budgets. We're going to see recessions in our own country, which means there will be there's likely to be a growing narrative around is investment in aid a good investment. An investment in sexual and reproductive health and rights overseas is a great investment. So really help tell that story around how positive investing in SRHR is, how it does actually contribute to a much more resilient and peaceful world.
Thanks. And Rory?
I think for us, one of the most important things are, particularly with access to abortion services being new in the last number of weeks, that people know where to contact to access those services, that the central access point is now there and that they can access services locally. So we do share information on our website, on Facebook and Twitter. I would encourage people to also share that, to discuss it with people, to contact their local politicians as well, to push for the full commissioning of those services. Grania had mentioned in terms of petitions that Amnesty have in relation to telemedicine. That's another thing that people can share as well. But I think it's important that people know that services are now available in Northern Ireland and that they can be accessed. And we need to go obviously beyond the 10 weeks that is currently in place. And hopefully we will see that shortly.
Okay, thanks, Roy. So I've been asked a question here just specifically on Northern Ireland around whether or not the UK government will be doing checks to ensure that Stormont are fulfilling their responsibilities, that our provision continues to be in line with CEDAW and accessible. So as I mentioned, the responsibility of the UK government, does not end here. The Northern Ireland office specifically is responsible for ensuring that our rights are vindicated, that they are fulfilled, and that the legislation and regulations that are now in place are given effect, and that includes in practice. So the accessibility of our services throughout our health system here, throughout the NHS. So that work is ongoing. There are some other issues that the Northern Ireland office have said that they will keep under review because they did consult around the regulations, and that specifically refers to issues like safe access zones or buffer zones, exclusion zones. They get all of those names. And I think, particularly for organisations like Inform and Choices NI, and for the other, for those who will be delivering these services day and daily, that will become something post-COVID that will be very pressing. And I think it's really incumbent upon our Northern Ireland Executive and the Northern Ireland Office to ensure that those safe access zones are delivered, because really the bottom line is women and girls need to be able to access these services, and our healthcare professionals need to be able to provide them free from harassment and intimidation. So if I could just then pick up on the next question, for many of our country contexts, the potential is there for a second wave of COVID. And if learning and sort of reflecting on, that we're now coming through this first wave, what would you like to see done differently? I presume that refers obviously by government, but also obviously wider than that. So maybe if we start with you first, Sarah, on this.
So what would we like to see done differently? I think now we know the second wave's coming, a lot could be done around pre-preparedness. So, for example, in terms of access to contraception and safe abortion medication, ensuring that products are pushed out from central warehouses and they're pushed down to district warehouses and into the facilities. In many of the countries in which we work, there were initially, there were huge risk of stock out because transportation within countries was restricted. So the supplies couldn't get out there, but also the global transportation routes were severely disrupted as well. So shipments that should have been coming in were delayed. So, we want countries to really start pre-ordering and stocking up and then pushing it out to the facilities. And similarly, with providers, where there's task sharing, which means allowing lower cadre health providers to provide safe abortion or contraception, empower them, change policies and empower them to provide these methods, because often women can get to a rural health post before they can get to a general hospital. So I'd say task sharing and pushing the commodities out.
Thank you. Elizabeth?
So I think probably most people watching this are aware that rates are not going down of COVID across the US. In fact, there are, I believe, 14 states where the rates are going up. So yes, the second wave, but also we are still absolutely in the first wave in the US. But in thinking about how we could ensure the provision of reproductive health care, states have a large sort of leeway in emergencies to stop enforcing some of their laws. So as I said, there are 18 states that prohibit the use of telemedicine for medication abortion. We did see a lot of states loosen telemedicine restrictions and allow lots of other types of healthcare providers to utilize telemedicine during COVID. And so we'd like to see some of those restrictions on telemedicine for abortion care either not enforced during the pandemic, but frankly, repealed altogether so that people can always take advantage of them. And then I think too, all of the litigation that the center went through and that our partner litigating orgs filed, in the vast majority of that litigation, courts said no to the states that wanted to prohibit abortion because of COVID. So I'd also like to see those states, I'd like to see those states full stop, change their behaviors and not continue to try to prohibit abortion all the time, But certainly when we see a second wave, if we see more of these orders that would limit healthcare provision in order to conserve personal protective equipment, I would ask that these states do not go down what was, an unsuccessful path this spring again, so that we can ensure that people can still access abortion care.
Rory?
And I think on that, and Sarah had mentioned the importance of preparation, and I think that's key. In terms of our Department of Health here, there was an over-reliance on a UK government scheme in terms of people travelling to England, and it was only when we started seeing travel restrictions and people not being able to travel that they were forced to, some trusts, provide these interim services. We can't let that happen again. We can't go back to a case of a rollback of some of these services and then wondering what happens next if those travel restrictions are introduced sometime later in the year. So there needs to be preparation. The Department of Health needs to be looking at the services that are in place now and building on what is there rather than coming back. So I think that's important. I also think Grania had mentioned the fact around safe access zones. At the minute, there may be less attention to them because we are in a state where we can't gather outside premises, but we know if informing choices were in our office currently, or if people could gather, we've had a history of being picketed as an organisation for over 20 years. So I think we need to be looking going forward about what is going to happen when we resume to somewhat normal times where people could potentially picket, and we need to be doing something about that now to ensure the safety and long-term longevity of the services that are in place.
Yeah, no, I agree with everything that Rory has just said there. So look, time is fast upon us here. So let me just ask then, a question's come in, if we have seen the profile of those accessing abortions during this period change at all, and what could that mean? So Rory, maybe if we start with you this time.
Yeah, and in terms of what we may see now, I know in terms of a number of the people, we know generally in terms of when you look at the statistics for people who have travelled from Northern Ireland to England to access these healthcare, just over 50% already have children. From the conversations that I have been having in the last number of weeks, the majority of people do already have children. So you are speaking with people who are in existing relationships who have multiple children already. You may be seeing the age demographic is slightly older than previously because people aren't going out to the same extent and socializing as well as what we may be doing in normal times. So I think we potentially will see that profile changing. I think at the minute, though, the service in Northern Ireland is in its infancy. It has been running for 8 weeks, so it is probably too early to tell, and we will probably need a longer term in terms to study that data. And also, I suppose the issue is we've never had a full grasp of who was accessing abortion in Northern Ireland. We have statistics, obviously, from people who have travelled to England. We've never been 100% aware of how many people exactly have accessed medication online and the breakdown there. I know some of that information has been provided. So we have never had a full data set in terms of how many people will access abortion. It's my view at the minute currently that age group may be slightly older and may already have pre-existing children, but it's probably too early to make that assumption. We'd have to see a year down the line in terms of whether that bears out in terms of the statistics.
Thanks, Rory. And Sarah?
Yeah, that's a really good question, but as Rory said, I think it's probably a little bit early to answer that question properly because the data's only really just coming out. I know in South Africa, where we launched telemedicine in March, we found there that the majority of the women using that service are really rural women. And, we think that potentially we could be reaching women who maybe prior to telemedicine would not have been able to access our services so easily. In other countries, we're seeing, we're hearing of spikes in gender-based violence. So we're anticipating that a lot of the women using our services are maybe living in violent situations. But yeah, it is really a little bit too early to tell yet, I think.
Thank you. Elizabeth?
I would just echo what's been said in terms of data on who's currently accessing care. I will say that there is a concern that more people will seek abortions later in pregnancy in, now and in the near term, because so many people couldn't access care while the COVID orders were in effect. And, it is harder to find, there are less providers who provide abortion later in pregnancy. And so there is a real question of capacity. But again, we haven't seen the data yet. So those are just concerns that that reproductive rights advocates providers are working through and planning for.
Yeah, I think Elizabeth made I was just going to say, I think Elizabeth made a really good point there about the late term, the later abortions. Women are going to be accessing services later, and in many countries, second trimester abortions are actually legally restricted as well. So this is going to cause huge problems and potentially force women to have to resort to unsafe methods.
Thanks, Sarah. Okay, so we have 2 minutes left. So very quickly, and if we can all do this very succinctly, just ending on a positive note and just hopes for the future with this campaigning and with this area of work. So I'll maybe start with you, Elizabeth.
So I've already mentioned voting. I will just say that there's more of a conversation now in the US around the importance of abortion rights and abortion access, because we have seen what happens when abortion is limited. So my hope is that there will be new legislators across the states in Congress, and that those people will be supporters of abortion rights and make different laws than the ones we currently have.
Great. Sarah?
I think we've seen some great innovation during the COVID crisis, such as the telemedicine in Nepal, the telemedicine in South Africa, and I really hope that these temporary measures actually become permanent and actually inspire other countries as well to take similar action and roll out telemedicine services where they can.
Thanks, Rory.
Well, we've seen access to abortion increase in Northern Ireland. We want to keep on building within that. We want to see services that fully comply with our regulations, so that people are no longer forced to travel or to access pills online. We want to see telemedicine being introduced, and then we want to see this as part of a wider package in terms of improved access to contraception and better provision of relationships and sexuality education in schools.
Great, thanks. I suppose I would just add that we are at a crucial point in Northern Ireland where now we have won the battle around our law reform, and we now have these regulations in place. So really it's about now how we normalise and embed this healthcare in our health services here, and also how we continue to have those conversations as a society that abortion is just one aspect of a woman's reproductive healthcare. But I want to say a big thanks to our speakers this evening and to you all for joining us. And we hopefully will be back soon. Thanks.
Thank you.